Welcome to At the Nurses Station with Kelly and Sam, a podcast for nurses about everything except the patients. Today we actually have our first interview. I'm really excited. It's Dr. Rocholl, and we are going to be talking about how to be a doctor's favorite nurse. So get excited for, what I'm hoping is some good advice. It might get a little intense here and there, but Dr. Rocholl is a great doctor to talk to us about this. So really briefly, we're just going to kind of tell you guys a little bit about him.
Yeah, so Dr. Christian Rocholl, he has been on the front lines of pediatric medicine for nearly 2 decades. Been a doctor longer than I've been a nurse, so he's older than I am. That makes me happy. Just to be clear, while we are interviewing, I will be calling him Chris because I call doctors by their first name. And Sam will not because she thinks that that's not appropriate. So she will be calling him Dr. Rocholl.
Yeah, they're doctors, so that's what they get to be called. But Dr. Rocholl is a board-certified pediatric emergency physician at the hospital that we all work at, which we have decided not to name. But in our region, he's helped build and lead our only pediatric emergency department, which is really amazing.
He also recently has been the program director for the pediatric residency of a university close to us. He's also spent his years shaping medical education, improving quality of care, and leading national pediatric initiatives.
Which is really all to say that for all my nurses out there, he's really the doctor that you want to impress. We all know those doctors on the unit. They're a little, dare I say grumpy? Is that the right word? I mean, yeah, kind of. But they know what they're doing. They've been around a long time. And if you're going to make a good impression on anybody, these are the doctors that you want to do it on. So today he's here to tell us what makes not just a good nurse, but really a great nurse from the doctor's side of the stretcher. So Dr. Rocholl, welcome to our podcast. We're excited to have you.
Hi, Chris.
Thank you very much for the introduction. So basically I've learned that I'm old and I'm grumpy.
Oh, yeah. Well,
I think I tell you that every day.
In only the best ways. But before we go on, I just really want to remind, Kelly, I don't need to remind you, but Dr. Rocholl, we are looking for just real answers. I don't want you to be afraid of other people's feelings or offending someone, because really the idea of this podcast is to kind of have the conversations that we all need to have or like to have, but don't always get to talk about the most. So since I've been told that I'm the only one responsible enough to drive this ship, I'm just going to jump right in and talk about nurse and doctor dynamics. And it's going to be mostly a question and answer format. Take as long as you want, talk about as much as you want, and we'll get through whatever we can. If you want to remember way back when you were a new doctor, I know that baby doctor isn't the preferred term, so I'll try not to use that. What did you think of nurses when you first started out? How was that? How were they kind of framed in your career?
I think some nurses understand the process that it takes to become a doctor. Not everybody does. So a lot of the times the terms may not necessarily be self-explanatory, but you go through med school and then you decide what area you're going to specialize in, either a surgery area or a medical area. And that's when you decide you're going to do a residency. And then your residency is anywhere from 3 to 5 years. And then you decide on if you're going to further specialize after that. And then that would be called a fellowship. And then we use the term attendings in the academic standing to mean that the doctor who's in charge, but we don't really use that in our department because we don't have that many levels of learners where we need to differentiate that. The nurses know who's in charge, who they're working with that day. My sister is a pediatric nurse, now retired, but she was a pediatric nurse in a, dare I say, sort of inner city environment in New York City. And so had a lot of experiences. And she graduated from nursing school when I was in college. And so I certainly, as she was starting in her career, had, some ideas of what the life is like for a nurse from the home side and the family side, and then to go to work and what they bring home with them. So I always kind of, had that in my back pocket. I think it's very intimidating for a baby doctor to be making that transition, or a med student, and having the same type of communication issues that a new nurse may have, and their fear of approaching a doctor, whether you guys realize it or not. it's sort of jokingly, but I think the nurses carry a ton of power, right? As a baby doctor, the physician that we're working with is the one who might be grading us and might be the one who giving us evaluations. But the senior nurses are the ones who can make our lives enjoyable or miserable, depending on whether we impress or fail to impress them.
Okay, so that makes sense. So overall, have you had, as a newer doctor, then maybe more positive experiences with nurses since you had a more personal understanding of what their role was and what their challenges are?
Yeah, I've seen the full gamut. Like, there's good doctors and there's bad doctors, right? Like, I had discussions with my neighbors over the weekend who were asking me, some questions about COVID and their perspective. And I said, there's good doctors and there's bad doctors, and you're going to get different experiences. And I think that there are good nurses and bad nurses, and there's good people and bad people in every profession.
Totally.
And so I think I've seen the full gamut. And I think, more often than not, I feel that I really rely on the nurses to be an integral part of the team and at times an extender of what I'm trying to do for the patient. And so you really come quickly to learn who you can rely on for that and who you can't. So as a general, I think I've had much more positive experiences, but I've certainly had some negative experiences along the way.
Sure. I like that you kind of touched on being part of a team and the extender of your practice. So when I think of our team kind of in three parts, we have the doctor, the nurse, and like a tech, CNA, or whatever your unit describes them on. Whereas like the doctors are like the brain, the decision makers, they evaluate and then kind of decide what we're going to do. The nurses are like the doers. We're running around pretty much just doing a bunch of crap. And then I think of like our techs as kind of like the thing people, like they're the ones that know where the things are, can get me the things that I need, are like the managers of all of the items that I need. That's sort of the framework that I think of us all in. How do you place nurses in the framework of your practice? What role do we serve from the doctor's perspective?
I think that a lot of people would agree with you on that framework, but I think that's a dangerous framework when you say that the nurses are the doers. So they're the doers, but I think that their brains are so important. I think when I started in medicine, we did not have the same accountability that there is right now, meaning that, I hate to say it, but back in the day, we were very naive and were left alone in the hospital to do a lot. And it was sort of acceptable that the next day you would be somewhat scrutinized from your from the senior physicians, but in a way of making sure that you didn't miss anything. You would order everything. You would order every test there was. You would rely on the nurses tremendously because of that experience, because we did not have the level of oversight that there is now. So patient outcome, nothing but the best is acceptable. Nothing but minimal cost is acceptable. And so kind of going back, I just feel now we're in this role where, I'm a little bit of a tangent here, but back when we had paper charts, I very rarely made a mistake with ordering something on the wrong patient. And with Epic, I'm allowed to have 5 charts open at the same time. And so when nurses come up to me and say, hey, can we just order this? And we order that. And then at times I'll say, can you put that in? Because I know I have 15 things on my mind and there's a very good chance I'm going to put it in on the wrong patient. And so I feel like now on a daily basis, because of those distractions, that I will make errors by putting things in on the incorrect patient. And I really need an extender that is going to think, not just make that patient ready to go to x-ray, but think, does that x-ray make sense? So when I put an x-ray in on a cervical spine x-ray on the patient that's there for a foot injury, and the nurse just is a doer and just checks the box and makes that patient ready, then that check and balance falls apart if they're not using their brain to think about, does this make sense or not, right? And if it doesn't make sense.
When you say that you will ask nurses, because you do that to Sam and I all the time, like, can you put that in? Or, I'll just say, hey, there's a testicle pain in the lobby. I'll put in the ultrasound. There's certain nurses, or is there a point that nurses can get to where you trust them to that level? Or do you assume that all nurses should be at that level?
Well, I know that they're not all that level. And I know that, like, even in our department, we've gone through major changes with shifts in terms of the staff that I've worked with, as you mentioned, in the 20 plus years that, I've been here. And so I've seen that, and I've seen different responses where if somebody comes to me, whether I feel trust in them to do that or not. And there are times when I'm right about to do something where I'll just say, you know what, wait, and I'm going in that room, not because I don't trust that person or not. I have had a comment one time where somebody made a comment, not to me, but it got back to me, where they said that that they're not the doctor and they shouldn't have to do my job. And so, to me, is it my job, our job? Like, we're all there to take care of the patient, right? It's not a us versus a them. And so, I think if somebody's coming to me and asking me for something, if they have the time to put that in and it's going to prevent an error, then, I'm going to stand behind that. And if somebody feels like they don't feel safe putting an order in because I might not sign it, or, then if I have not proven myself to them to be able to do that, then they shouldn't do that. Then they shouldn't put an order in that if they don't feel comfortable. But I feel like if it's a verbal discussion, and usually it's witnessed by many people because it's at the nursing station, I'm not going to go back and say I didn't do that. But so some nurses are very much like, this is my license and I'm not, going to do this. And others understand that, what they're asking for, it's the best thing for the patient. It's going to be the most time efficient and the safest, to do that. And I think we're talking about two different things. One is like, is this just an ibuprofen order for a patient and versus what you're talking about then is more of a clinical decision making, and practice of medicine. And before you get to the next question, I have had staff say to me, like, they don't want to do that because the other provider on another night has chastised them for doing so. And I think the difference is, like, I had spent a lot of time on nurse-initiated orders and getting approval for those, and a lot of those have fallen by the wayside. And I think a lot of times on a busy night, I look to say, like, are any of those things getting done? Because they can really help expedite care in little ways. And so some nurses are very good about putting those things in. If a nurse just goes and orders a chest x-ray, there is no nurse-initiated order for chest x-ray. So, I've heard like, well, the doctor yelled at me because I put an order in, but you didn't do a nurse-initiated order and you didn't talk with the doctor about it. You put an order in for chest x-ray. Like, then that goes where I can't say that everybody's going to respond the same way. I would hope that if you came to me and said, I think this patient needs a chest x-ray because, then we would have a discussion. I would say, yes, please, let's get that going. And I would hope that my colleagues would be the same and open to that discussion. And I've heard that some are and some are not. So that's sort of
Well, I think that goes back to like the relationship that you build with the doctors you work with. I remember I was off for a back injury for like 4 months. And my first shift back, I came and asked you if I could put an order in. And your response was, the Kelly I know would have already had it done. And I was like, okay, good, we're back.
I get told about all these things that I supposedly said that I do not recall. Many of the techs tell me that they were very afraid of working with me. And I think, it's a challenging situation because, I came out of fellowship and came here, and myself and one other provider were getting the pediatric emergency department started. And I was at a very young age in my career to come to a place like this and do this. And then shortly after I got here, I was already being asked questions as if I was the medical director, and then was put in that position, and it was a little contentious, but it's a different relationship when I'm responsible on the other side to the hospital and responsible for things. And then when things don't go right, I have to critique. And like for me, after doing that for almost 8 years, it was almost nice to take that off of my shoulders because I feel like I can have a very different relationship with staff. And then like all of a sudden techs were able to come to me and say, oh, we were so afraid of you. And some of that was just because of the title that I had, not necessarily, I think, because of my actions. But there are quite a few nurses who say that their first experience to me was, that was awkward or that I was intimidating or in some way. So I I don't know if that was, some of that, the role that I played, because I have been told that I asked for feedback from all the nurses regarding the providers when I was doing their evaluations. And, at one point I got feedback that I was not controlling, but I can't remember the term they used. And I just came from a place where there was a lot of feedback when I did my training. And so, now to have Epic and people be like, I know, because I put an order in, but I came from a place where everything was verbal and we had communication about things. And then so all of a sudden to be people telling me I know, but then there are other times when people would not follow up on the order. So I just was very much to have that communication and make sure that the nurses, the techs, everybody is on the same page about what we're trying to accomplish with this patient, so that if things aren't going well but yeah, I think trust is everything in medicine, with learners, with everything. When you have nursing students come in, you have to build a level of trust to allow them to do things, right? And it's the same thing with me, and I think it's with my learners, and it's also the same thing with the team. I have to have a level of trust in you, and you have to have a level of trust in me. I wouldn't want you to be a doer and do something with a patient if you didn't trust that I was doing the right thing.
If I can jump in, this is we didn't ask you on here because you're grumpy and mean, Dr. Rocholl. My stance is really, and Kelly obviously comes at this from a different perspective, but I have always appreciated how seriously you take your job. And I think maybe my first 2 shifts with you, I made low level mistakes. I remember for sure grabbing the wrong NG tube and putting it down this 12-year-old, just because there's different materials available. And I didn't realize that we couldn't feed her through it, that it was only an NG tube. And coming to you and just being you probably think I'm the stupidest nurse and I'm so sorry. And I want you to know that I will get better. Anyway, but like we said in the beginning, that's the reason that your opinion matters, I think, and why you're a good person to ask this, because there are good and there are bad doctors, but I will always take the doctor that maybe tells it like it is and is, I don't really think that you're grumpy or rough around the edges. I think that you just expect competence from the people that you work with. And I think that that's totally reasonable. But those are the people's opinions that we want. I don't know. I'll always take someone that's slightly not nice over someone that doesn't know how to do their job, because that's not acceptable. I know. Yeah. But I think you're absolutely right. So I think you kind of got into nurse-doctor dynamics perfectly for us. Trust is the most important thing on our unit, no matter what we're talking about. But that's definitely not something that you can cultivate within the first couple of hours of working with someone, no matter what our roles are. And sometimes that's something that really takes years and different types of situations. Oh, before we move on, NIOs are nurses' jobs. So I just want to be really clear about that. If there's an NIO,
yeah, we actually had a whole episode on triage, and Sam and I went off about NIOs, and so you're not done, you're not doing your job.
It's not a doctor's job, it's a nurse's job. That's what they're there for. And I think there is a chest x-ray in the chest pain NIO.
There is one in the chest pain NIO. And I was talking specifically about a patient with bronchiolitis where somebody ordered an x-ray, and then one of our other providers got very upset about it. And I think I'm only joking about the grumpiness. My family says that I'm grumpy as well. So it's not the first time I've heard that. But I embrace it. As far as the just with the orders, it's beyond the NIOs. Just my expectation would be is if that you see a patient that you think needs an x-ray, that you would come to me and say, or any order, hey, I know there's 6 patients waiting and you have a lot going on, but I think this patient really needs this and this is why, as opposed to just doing a triage and sitting there and waiting until, I was coming. And that's more or less where I was getting about doing the doctor's job. I feel like what is the limiting factor in getting this patient the care they need? And there are times of the day where the nurses are overloaded, and maybe the nurse is a limiting factor. And I might go above your head and go to the charge nurse and say, where the resources are. And this nurse just got 3 really sick patients and they need help, and this needs to get done right away. And then there are times where I'm the limiting factor because now the time of day changed and the nurses are caught up. And in those situations, then I would hope that the nurse would come to me and say, you're an hour out from seeing this patient, but, I think this is what's going on. What do you think about me getting some things started?
Yeah.
And that's where I was kind of got feedback where like that's the doctor's job to make those decisions. So
you just text me the name of that person. I'll take care of it for you.
Thank you.
Well, and I was just laughing when you said that about the nurses being overloaded, because there's just a funny story where we actually have called Nurse Christina, because all the nurses were behind, and he actually called bedside report for a nurse, which
and I called the surgery center.
Loved and made fun of for so long because he was giving nurse to nurse report because we were behind, which is awesome.
And I called Shane at the surgery center, who came down, and we did a cath urine LP and an IV on a baby while you guys were all in the room that night also.
Of course. Which is great. And that's what a good relationship can look like. I think that there are other options there. I will say my goal is to always have your orders done before you tell me about them. Because instead of just saying, I know, it's better, I like being able to say, yeah, it's done.
It's done.
The Tylenol's given. Whatever's done. Thanks. But if we could talk about like specific nursing traits, these are the kinds of things that I'm actually really interested in, to see the changes from the generation before us as nurses and the generation like coming up. Like, what traits do you actually want to see? Maybe we'll say off the jump, your first experience with a nurse, and then like the first like 3 or 4 months working with them, just because we don't, shifts are kind of different for you guys. So maybe you don't get a lot of time with each nurse as they start. So what kind of actual personality traits or work-related traits are you looking for in a nurse?
It's sort of, I guess, the situation we're talking about is where I've been working in the unit for a while. So I'm assuming like the nurse is new. So it's like me seeing, a new nurse coming to the unit, right? It's not like me going to a unit where the nurse has been working forever and then I'm trying to figure that out.
Maybe.
I mean, it could be. I'm just saying, like, my experience, I don't really have a lot of experience in that latter situation. Mm-hmm. My experience is more of seeing the turnover and having newer nurses, and then how do they fit into the unit.
Okay.
I think, one of the things is like when somebody's new, and I think the best way I always kind of feel like actions speak louder than words. And so, somebody comes in, just sort of keeps their head down, does their job, but communicates. And by head down, I don't mean is quiet, but I just mean like when you're involved with the social aspect, or you're, more concerned about being on your phone or things like those, obviously to me, things right away that are sort of turnoffs with regards to the relationship. I think that, and some of this is on me to probably do a better job in introducing myself. Everybody knows who the doctor is. Like, there's only one doctor, or maybe two, depending on the time of the day. But there's so many nurses, techs, people that come through, and people that are there for 2 months and then leave, and people there 3 months. So I always joke, and I think I said to one of our nurses, we're not using names, but I joked and I was like, well, you should feel pretty privileged because it usually takes 5 years before I learn your name and I know your name. And she said, well, is that good or bad? But I think that for me, actions speak louder than words. And so I think all the providers can kind of tell how seriously a nurse takes their job and whether their patients and their job are important. So you can tell very quickly when a person at any job, whether their goal is to do as little work as possible during their shift, or whether they're there to be a part of a team. And I think, that kind of stands out. And to me, I'm much more willing and wanting to work with that person as opposed to the person who's just there to try and get through their day. I mean, without doing anything, then I tend to try and avoid that person.
Okay. I want to jump in there because I think it's a small thing that you said, but I feel like it's really important, and that is introductions. Mm-hmm. I know when I first started in the ER, I hadn't started on a new unit in a long time. And I remember like walking up to you and saying, hi, I'm Kelly. My background's in NICU and PICU. Do you prefer if I call you Dr. Rocholl, or do you mind Chris? Because to me, that's important. Like, are you okay if I call you by your first name? Mm-hmm. And almost every doctor will say, oh, no, Chris is fine. And I think just setting up that stage, and I actually think you do a good job at this, is I've seen you walk up to new nurses like, hi, I'm Dr. Rocholl. Are you new here?
Yeah.
And I think that just sets the stage for like a positive environment versus you've been at work for 2 months and you've never actually like had a personal introduction.
Yeah. I think communication is important, and it's a lost skill, right? Like everything nowadays is, we're doing this virtual, and 15 years ago, this didn't exist. We would have been in a room doing something, together. But I think it's an unfortunate thing. I see it in my own children, comfortableness being in awkward situations or new situations. And I think you can just either embrace that or it can really overwhelm things. But I think if you're going to be a successful nurse, you need to be able to go in and command a situation when you're speaking with a patient or a family, and be able to be comfortable with introducing yourself. And then that would go, hopefully the providers, the physicians and advanced practice providers aren't intimidating, in that respects. And for myself, I'm absolutely fine. And Chris is absolutely fine. I think in front of patients, it is helpful to distinguish that, because it's particularly for my female colleagues, if you're calling them by their first name, they have a harder time, so I'm told, being revered as the physician, particularly if they're not given that title in front of a family or a patient.
Yeah, absolutely. I agree with that. Yes. I always say doctor in front of the patient, but I feel like it's different at the nurse's station, right?
Absolutely.
Yeah.
So disagrees completely.
That's okay. I mean, we did have one doctor when I first started that she was very insistent that I use her first name. And I guess if it comes to that, then of course, like I would want to respect whoever's wishes by speaking to them in whatever way they would like to be spoken to. But, gosh, Kelly, it's just not how I was raised. Okay. Like all of my children call all of the adults in their life by Miss or Mr. Doctors are doctors, pastors are pastors. I don't know what you want from me. So that's all I can.
Sure.
Yeah, I can't change. I'm like halfway through my lifespan already. So it's just is what it is. But okay, so we've talked about like more normal interactions on the unit, kind of lots of patients, lots of things going on. What are some traits that you appreciate or want to see or would encourage us to be better at in a trauma or a code? Because I think that sometimes those are different skills and different, just different skills.
Yeah. I mean, there's always going to be the basic skill sets. And I think during my time, I have seen, nurses who are, for access, for example, there are nurses who are very comfortable and do a great job with access. And then there are nurses who start out and may not have that. And I think for me, if I was going to be in a code situation, there's enough downtime at certain times of the day, right? Like our unit can be crazy busy, but there's downtime where you could ask your colleagues to help you so that you will be successful in those situations. We had a rapid infuser, and I saw one time a nurse was speaking with another nurse and said, "Oh, I hope I don't have to use that. Nobody's ever taught me on that," or something. And I was looking and I was like, the unit is empty right now. So then why wouldn't you say, I don't feel comfortable with this. This is an expectation of my job. How do we do that? I know several nurses who worked with us as techs who were just very uncomfortable, or even newer nurses with doing IVs. And it was almost like you just knew when they came out of the room, they were going to just ask for somebody. Like, I don't even know if they really even tried twice. But rather than trying twice and knowing that you're going to fail, like, why not ask somebody to go in and work on your technique? Or even if it's on your own time, ask to work with the IV team, in a more, controlled environment. I just like that is your trade. And I'm really sensitive to the sick patient, whether it's a trauma or a medical code, because I did 3 years of training after my residency in emergency medicine. And the reality is that 3 years of training is for like 1% of our patient, right? Like, so some people come in and they think like, boy, we did a great job because we moved 100 patients today. And if there are 100 patients and 90 of them don't even really need to be in the ER, did we, how great of a job did we did we do? Sorry, if we didn't take care of that one patient who was really sick as good as we should have. And so I think like if you're going to work in a peds emergency department, then that should be your goal, is to be able to, know your meds, know your access, know your vital signs, know how you can help, how to keep that situation calm. If there's a tech or someone who is not doing the right thing, but how to appropriately control the situation without adding to the excitement for that 1%, for that one patient that might walk in once a week or once a month. How do we take care of that patient the best? The other 99% of patients, no matter how mad they are for waiting in the emergency department or long, like I feel like sometimes we focus more on moving patients than we do taking care of the sickest patients. So I kind of may not have answered your question, but I think that needs to be the mindset for a successful pediatric emergency nurse, is to make sure that their skills are there and that they recognize that patient. Mm-hmm. Right. I think for me, it's not, again, I'm not going to the trauma or code, but there are some nurses who come to me and tell me about every single one of their patients. And they make it out that every one of their patients is my biggest priority. And then there are nurses, who, and I think if it kind of takes away then from, it's like the boy who cried wolf, right? Because then I'm like feeling like I need to go in, and then I'm like, okay, well, they came in by ambulance, but there's been people waiting here 2 hours who are probably sicker than them. That's not my first priority, and sort of kind of helping to recognize that. Is it really the right time to be coming in, again, with the distraction when I'm doing multiple things, to tell me about a patient who is not going to be the next thing that I need to take care of?
So if I could condense it.
I can, but that was sort of what came to my mind when you were asking me about that. Like
competence for sure, as like a skill, like be good at what your job is, because that's your job. That seems reasonable. But maybe as more of like the traits, what do they call them? Soft skills, if you will. What I heard is like the ability to be calm in those situations and be effective, to set that tone. So when I think of some of our more rapidly changing situations, if you will, not having a nurse that's like frantic, or not having a nurse that's increasing the volume unnecessarily in the room. Those are the kinds of things maybe that would make your job easier, or doctors see as positives in nurses in those situations.
Yeah.
I think it's that, that meme or that video that always shows when you see the new grad sprinting down the hallway and everybody just kind of turns and looks. Whereas you see like samurai sprinting down the hallway, like you'd get up and follow.
If you see me running, please run after me. I'm not running for any, like I need people if I'm running. Okay.
One of my biggest pet peeves is when I get called to a room about a very sick patient and I go in, if I'm in there, then if the nurse walks out and then all of a sudden is sitting there charting, like if I'm being called to a room because a patient is that sick that I need to be in there, then we should be having a discussion as to what is the most important step. So, if I'm called to a room because a patient is having anaphylaxis and then I turn around, I can put the order in for the epi, but it would be great to just give you the verbal so that while I'm putting it in, somebody's getting it, as opposed to that nurse now all of a sudden is charting their assessment and I'm looking for who's going to do the interaction. So my biggest pet peeve is being called into a room for a very, what is perceived as a very sick child. But then now I'm wondering, how are we going to proceed with the plan that I'm coming up with? And so I would prefer to be talking with the family and the nurse at the same time. So we're instituting that, as opposed to, when all of a sudden the charting becomes the priority in that session. I'm like, we're missing the boat here. You just pulled me out of a room to come into this room. And now we're at a stall because we don't have a clinical nurse at the bedside. I love
that. That would be, I can't even imagine operating in a way that I would have a fit if I saw a nurse. I mean, also because if I dragged you into the room, honestly, Dr. Schultz, because I want something out of the doctor. Like I want something that I can't get all by myself. And that is in order for epi. I mean, I guess we can kind of order racemic, although I think providers have different
Sure.
like comfort with that one. So like, you know,
and I was even saying like an injection of epi or anything, an IV, a septic kit or any of those things. And you want something because you want something better for the patient. And I feel like some nurses just want the responsibility passed to someone else. So they want, you know, the physician in there. So now it's their responsibility and then they're going to go and chart. Whereas are we like, what is the priority here? Is it to move patients and be caught up on our charting and work, or is it to get this patient the care they need as fast as possible?
Yeah.
And I think it's also important that you said you shouldn't be talking to the doctor about every patient. Like,
yeah,
if I come to you and I'm having a conversation about everything, you're just tuning me out, right? Whereas if I'm like, this kid doesn't look good, you're going to be like, okay, I'll come. I'll be there as soon as I can.
If I may, is it a bit of and this would, I guess you can comment on this, Dr. Rocholl, too friendly of a relationship with the doctor? Because if I'm going to comment on every one of my patients, that comment is going to be to a nurse at the nurse's station that's sitting there with me. Like, I'll come out and be like, these people are, oh my gosh, they had like the sweetest kid or something. Like, when I'm making lots of comments about my patients, it's more in just like a conversational way. So if I'm commenting to my provider about every single one of my patients, I don't know.
No, there are staff in our department who come to me, and I'm assuming my colleagues, with a report with an expectation that like this patient needs to be seen next. And it's all of their patients, and they, for some reason, feel that their patients, like it's a priority, and not looking at the general department and saying, you know, there's 8 patients waiting to be seen. This patient came in by ambulance, but I would appreciate you coming in and saying this patient came in by ambulance and they can wait like everybody else. You know, our system is too much geared towards putting ambulances in room, whereas other places I worked at, you had to go through the waiting room and you were stopped at triage and assessed. And the nurse frequently said, go have a seat, you know, in a chair. I'm not talking about just like, you know, conversation, particularly when it's not busy, but I'm talking about like, this is a priority, and not looking at the greater whole of like, there's much more sicker kids that, you know, need to be seen. I think there's just a lot of distractions in our department, and the more charts we open, the more we hear about things, then the greater chances there are of errors.
Sure. So takeaway would be like, be considerate of your doctor's attention. Right. And really only bring things up that need to be brought up. Do you have any, well, I know we're going to get to an advice section, but maybe those will be friendly thing. What about nurses that are nervous to talk to their doctors? Any like advice as to ways that they could do that, or they could shake off their nerves, or you just say, just talk to them because they're just people too, or what?
Yeah. I mean, I like the idea of they're people too. I think, there are certainly certain doctors in certain professions that carry certain stereotypes that, you know, are harder to talk with. In our profession, I think in general, pediatricians are thought of as easier to talk to, and most of us are pediatricians and then ER trained. Some of our doctors are pediatrics and ER trained, and some are ER trained with pediatrics at the end. But I would hope that most of our department is fairly approachable. But I think, you know, that stigma is not really acceptable anymore. And it's not an excuse that you're the doctor and you have it hard, and that gives you an excuse to be nasty. And I think for a nurse, I think you have to try, right? You have to, you know, put yourself out there. And I like Kelly's idea of like, hey, I'm new here. I have not seen that from any of our new staff in the last few years where we've had a lot of turnover. I think, and our techs. I mean, I haven't had anybody say to me, you know, hi, and maybe that's an administrative thing or something we put in, but I haven't had anybody say, you know, hi, I'm so-and-so, I'm one of the new techs here. And, you know, for me, I'm always like, can you update the board? Because there's so many new people running around, and I have not met everybody. And so I try and look at the board so that I can go to somebody and say, hello, so-and-so, or, you know, hello, so-and-so. My understanding is that you're taking care of this patient. But when the board's not updated, that's why I like the boards in the room, so I know who I'm working with. But there are a lot of staff that I don't know. And I think sometimes, I mean, it's human nature. I think sometimes the physicians are thought like that they should be above that. But I think that sometimes our physicians are hesitant to go out there and make that introduction, as well. So
we do work in a small utopia department for sure. We have very approachable providers. We have generally a small staff. We do have a lot of turnover, but I feel like nationally, on average, that's probably not really true. Even if you look at the adult side, way more nurses, way more providers. So I guess more you're saying make the introduction, maybe give some background. And then when you want to talk to a doctor at other times, even if you're nervous, just do it and make it like, how would you do that?
I think that when we go into a room and I don't know the nurse in front of the family, that looks awful.
Gotcha.
And so I think that, us having some type of a quick, introduction or a quick, that we recognize each other, as opposed to going in the room and I'm like, are you the nurse? Or they're like, and who are you, in front of the family that's, providing us with their care. I think that, that does not look great. So I think that whether it's the responsibility of the physician or the nurse, or whether it's just both of our responsibility, I think that it is really important at some point to make that introduction so that we're not going into a situation where we both have to be in the room at the same time and it's obvious that we don't know each other.
Gotcha.
And you touched on this, but I feel like it's a little bit of a generational thing too. Chris, you and I both have teenagers, older teenagers, and it is frustrating. It's like you have to have that just baseline communication skill. You have to be able to walk up and say, hi, I'm this person. So I feel like for the newer generation nurses that are listening to this, like if you were my daughter or my son, I would say, suck it up, right? Like you're a professional. So suck it up, go say hi and, move on with your life.
This is not the career to go into if you're going to have, issues with, being overly introverted or overly shy. I mean, you're going to be meeting, particularly in the ER. I mean, every single patient you meet, you're meeting for the first time. You are meeting new people over and over again. And we're making it out like there's, turnover. And I just mean like where, during COVID, we had a lot of experienced nurses leave. We had a lot of newer, younger, or just newer nurses coming to our department from other places. And so it's not like it's an everyday thing, but it's just, when there are new people, eventually you're forced to communicate with them. It just seems like it would be better to, do that earlier. And then, for me to know who's a student, who's there, permanently, I think what's the term that we use, a nurse tech, or, we have different roles in terms of who can do what. So I'll go to somebody and be like, hey, ordered IV antibiotics. And they're like, that ain't me. Or, so trying to figure those things out. I mean, we have to communicate.
Totally. You touched on some red flags. What are some things that you like to see? Some green flags, some nurse behaviors or nurse personalities that you're like, oh, that's exactly what I want to see, or that's what I like, other than the introduction, perhaps. Are there any other things that you look for in your lots of experience with working with nurses?
Going back to that whole idea of the communication, to me, this is a team, and I have been challenged on things that I've done in the emergency department. At one point, I had the nurse practitioners and doctors doing the discharges to get, people out the door. Other places I've worked at, the physicians had access to the Pyxis, and we would give basic medications to, amoxicillin or Benadryl or Keflex or things. Because I've worked in ERs that had like a separate fast track area, and we didn't have a nurse. It was just a doctor and a tech. And so we would have, some Benadryl and Tylenol and ibuprofen and things. But I just think that if you have the patient in mind, that goes a long way. I think that nurses who understand that you can't put anything off in the emergency department until later. You never know what's going to happen 5 minutes from now. So if something can get it done. And then if nothing happens and you have that downtime, then you have that downtime. But, to kind of delay on things, and then all of a sudden, have either a sick child or something walk in the door, you never know what all of a sudden is going to be on your plate. The communication, when I'm the limiting factor, is going to be awesome. If you go in and recognize that a child is ill, then pull me out of a room and let's get that kid started. Or if a family comes to the ER from another facility with an expectation of this is what's going to happen, then let me know that. And if it's a reasonable expectation, then let's get that IV started, and I could put some orders in, like we're all over the fever and neutropenia patients, and we kind of, get that and getting things in. But a lot of times I might just go in and do an introduction and say, I'm Dr. Rocholl. I know why you're here. The nurses told me this. We're going to get this x-ray going because we're going to need this for your care. But there's a few people in front of me that I need to go see. But, I think families would be somewhat taken off guard if all of a sudden they were being taken to x-ray or a nurse was coming in and starting orders without having a provider. But if you let me know a discussion, I can at least introduce myself and get some of those things started. I don't know that all of my colleagues are always going to be, doing that the same. But for me, I don't want you to do my job, but I want you to work with me on helping the place run smoother, right? Like if you just see that I'm drowning and you just keep stacking things on and telling me about patients that are not a priority, then that's a distraction. So I'm not going to be as efficient. If we just let people sit in rooms without NIOs done, Tylenol and ibuprofen is an amazing thing, right? I mean, the entire world is petrified of fever. And yet the reality is, we know that may not be a concerning thing. And then when we can get those NIOs done, if I see a kid and they look ill, I might need to wait now an hour or two for that Tylenol ibuprofen to kick in and do a reassessment. Whereas if you do an NIO and I go in a room and a patient is bouncing off the walls and looking better, then myself and the parents have confidence that we can send that patient home and then be safe. So it's all about working together as a team to try and expedite things so that we are free to take care of that sick patient. We get the not sick patient home, in an efficient way. So the communication, the foresight, at one point you and I were talking about something and we were talking about the team approach and the hierarchy. And I feel like that hierarchy creates a little bit of that mystique where that new nurse might not feel comfortable with that introduction and stuff because that hierarchy is there. And so maybe not this, where one is, but maybe that, like
getting in trouble again, Kelly. Here I am all the time.
When it comes down to the end of who has to have the final say, in a patient care, hopefully the physician's making that right decision. But I see it more as a collegial, hopefully working relationship than that patriarchal. This is what I wrote, because then things happen that, I'm relying on the nurses to help make sure I'm doing the right thing as well.
I mean, I'm by no means advocating that nurses don't think. Please don't get me wrong. I'm just like 80% of the time. But since you brought it up, doctors and nurses not seeing eye to eye happens every once in a while. I would say I'm probably the worst nurse in our department about this, probably with some of our providers.
I know an old grumpy man nurse.
Oh, yes. Oh, well, if ever I can be on his side, it's a good day. What are some tips, tricks? What's the most effective style for nurses to understand when going into one of those situations?
Like how to question you.
Yeah, I think it comes, where is it coming from and how do you go about it? Right. So, if you're, if you come at it from a perspective of I'm advocating for the patient, and you come out of it from a perspective of I want to know, I want us to make this decision together, or I want to, I'm looking for an explanation or for the knowledge that we're making the best decision for the patient. I think, I have not had a lot of experiences that I can necessarily recall that would be helpful to use as an example, but, I have had nurses where they've had personal, thoughts about things, from background or whatever, where they may have disagreed with something. But
can you ever go over your doctor's head? Is it ever okay?
I have received phone calls when I was the medical director from nurses who were delaying a discharge on patients because they didn't feel comfortable with the provider. And so they were calling me, either I was the medical director or I was coming in at 11 o'clock. Because they wanted me to reassess a patient, they didn't think that, it was in the best interest of the patient to maybe be going home or things. I think that recognizing that there are going to be families that may not necessarily understand things, and if it's coming from the nurse understanding what's best, not necessarily just what parents necessarily wish. I mean, we get a lot of families who either live far away. And I joke that's the cost of living in paradise. You get an amazing spot, but you live far away from the hospital. But I think if you're truly coming from it, then your situation would be that you would reach out to either your house supervisor or to, Dr. Barger as the medical director.
Sure.
For that. And it's going to be sticky. Like that's not going to, there's always going to be a question. I can think of a doctor who used to work in our department and a nurse who used to work in our department who used to get into it all the time over silly things like capsules versus liquid or, like things to the point where it became contentious. And that was just a rift in personalities that I don't know. To this day, I don't think I would ever put the two of them in a room together, but like that's silly stuff. But I think if you're really concerned about, a patient, then, going to your charge nurse, and then for the charge nurse to be in the middle of it, it would be speaking with our medical director would be the person ultimately who the physician's answering to. So in the heat of the moment, I think the best thing is to try and communicate with the physician and just say, listen, I'm not just trying to question you. I'm trying to make sure that we're making the right decision about this. Because there are times when the doctors are going to be wrong and hopefully they're willing to recognize that.
It's hard to know what they're...
I'm sorry. I was just going to say that I don't believe in all the little acronyms, there's the word, that the hospital teaches us, but I have felt that like the cuss is a good thing, that I'm uncomfortable.
Oh, yeah.
This is unsafe. This is a safety concern, or stop, I have found that the newer doctors, I think they're taught that in medical school. You can tell me that, Chris, if they are or not. But I know that in my past, if I come and I say I'm uncomfortable, that usually will get the doctor's attention instead of being like, can I, ask you a question? Just having that, hey, I'm uncomfortable with this. Can you explain this to me? Usually is a good starter to have that conversation.
I actually don't I find it very difficult I will ask a question once, confirm an order, make my concerns known. And if there's no discussion after that, or if those concerns aren't taken into consideration and I'm still given the directive to do what their original thing was, I personally find it very difficult to go anywhere else from there. There's just, I don't find that at least a skill that I have is to push even more. Obviously, if I think that it's truly going to kill a patient or it's wrong in terms of policies and procedures, I just won't do it. But yeah, I excuse me. But I think it actually is for some of us nurses more difficult to open the conversation, Dr. Rocholl, that you're talking about, where we really make a plan. If I present my concerns and they're just disregarded or dismissed or not considered, then it's kind of okay, well, I did my job as a nurse. The only other option is to kind of start a small argument. And I definitely don't think that that's ever beneficial. So
yeah, I think
then you start be aware
over and over again. Be
aware, and he don't care. Yeah. I think that it matters to what level of physician, right? So if you have a resident in training, and I have, the residents, and our residents are going to be coming through the ER. And I think if you're uncomfortable with something they're doing, then you'll have myself or the physician that know is ultimately in charge and going. I think that's a little bit of an easier situation to understand. I think one of the jokes that Sam and I always have is the oxygen on broncholytics or the monitor. I just don't understand why every single patient in our department automatically gets on a monitor, and then we have to react to things that they shouldn't have been on before. So Sam and I will always have joking conversations about that, and we may never ever get past that. But I think there are times where I'm going to just have to look at what is the capacity of the hospital, what is the real risk to this patient with regards to whether they had an a hypoxic event or whether their oxygen levels are running, lower than usual, but I still feel that they can go home. And so like, that's an ongoing joke. Like, I just don't want to know about it anymore. So, we're going to turn this
turn
off.
Off the monitor.
Turn off the monitor.
But I mean, hopefully if I was doing something and you knew more than I knew, I would want you to communicate with that, because I don't want to send anybody home. Like, ultimately, we all should be out for the patient's benefit. And I think, some of it I'm looking at like, well, what are the other things that are involved with this? What is the downside of being in the hospital? What does the hospital have for beds? Are we going to have to refuse to take somebody else who needs to be admitted if we're, putting all these other kids in that, and I also trained at a time when we didn't have oxygen monitors for everybody. And I don't think that we actually do a better job taking care of patients because of that. I think clinical skills then sort of go by the wayside. But
I just follow those NIOs that somebody wrote. So when it says put the patient on the monitor, I just do it. I don't know. No.
Yeah.
Well, I know I don't want to take up too much of your time, Dr. Rocholl, and the information has been really great. So just a couple of kind of like rapid fire-ish questions, just some advice for I want to say, we always say new nurses, Kelly, but honestly, this is advice that I have really wanted. As I've been introduced to new doctors, I've realized that maybe my skills of being a doctor's favorite nurse are not all that they could be. And if we meet at a bar, I'll explain more to you about that. But one behavior that immediately builds trust, if there is one, what would that be?
I think you can tell whether somebody confidence and not overconfidence. I think that, somebody who just kind of presents themselves well. I mean, if somebody's, seems meek and doesn't seem comfortable with their job, then it's hard for me to build, have confidence in somebody who doesn't have confidence in themselves. So that's sort of just, that personality, that ability to communicate and to, introduce themselves and make eye contact and communicate with parents. It just, I don't know, it exudes when somebody is there to do their job. And so I don't know if I'm really answering your question, but I think it's more of a gestalt thing of working with nurses and many different nurses in many different situations, from OR nurses to ER nurses to floor nurses. Because throughout my training, I've been in all those areas, even though I've been in the ER for 20 years. I have 8 years of training before I even got there, where I worked in all those different places.
Okay. Questions, or go ahead, Kelly.
No.
Oh, sorry. A question that nurses should be asking more often.
Of the doctor or the patient, or
either or, something that
I think that, one of the things I get frustrated with new learners is that the idea is they come to the ER and it's like, we're going to just ask all those questions, history, physical, whatever, and then they want to move on to the next patient. And I think that idea of like care all the way through, like I've been involved with so many meetings where we talk about patient satisfaction or patient experience, or what are the frustrations of families. And I look at like, well, who has the most amount of time to make the biggest impact? And the challenging thing is administration's talking to me, who I have the least amount of time to have that impact. And they might be talking to your nurse manager, but does that word get all the way down to the techs and child life and the nurses, right? So if you are caught up, is it the time where you should be sitting at the nursing station and meeting with, or is there a chance for you to go back and round on your patients who are waiting to say, we just looked and your CAT scan results are not back yet. We just want you to know we haven't forgotten about you. Or I'm just wondering, after those IV fluids, do you feel any better, right? Like some of you are really good about saying, okay, well, we gave the medicine, they're doing better, we're going to start a PO challenge. But I think those little things of keeping people updated, and that might be you doing that, or asking the techs to do that, or asking, child life to be involved with that, or a volunteer to be involved with that. But I think we do a good job of getting in, seeing patients, getting things started. But then we sort of sometimes fall off because we know what we're waiting for, but families don't. And so how do we be more consistent in that? And that's a big thing that I ask the learners that work with me to do, is that, if you're not seeing a new patient and you're caught up, then you should be going back through on the patients you have. We didn't talk about it.
Maybe asking like what what can I do next? Like if you have nothing
what
to
is
do,
my patient waiting for? So if my patient's waiting for an x-ray and I took over for somebody and they didn't make them ready, like it's a real pet peeve of mine. Of 2 hours in, I go in and I say, why isn't that x-ray done? And then all of a sudden we find out they were never ready. Like, we should be reviewing our orders and saying, well, this blood work's not back. I'm going to call down, as opposed to the doctor saying an hour and a half later and then finding out the sample, clotted and they, whatever those weird lab things that happen. But, that just kind of going through and is everything given? What are we waiting for? How do I expedite this? As opposed to, I've had situations where I go in 2 hours and I go to a family and I'm like, so how did that medicine work? Are you ready to go? And they're like, we haven't gotten anything. And I'm like, okay, like, I look dumb, but just that accountability and responsibility.
Okay. I like that. What are we waiting for? I should probably be better about asking that for sure. Is there oh gosh, Kelly, maybe you're going to have to ask this one. I'm not sure. Is there a best way to approach or handle you keep saying new learner or a learner, but a doctor whose first job on their own is in your unit? Is there a best way to help not handle them, but communicate with them, work with them, stop it? You're killing me.
So we all train at different places and we have different styles. And, one of the things that was challenging for me as a medical director was like, there's this bell curve and we all kind of are close to the curve. But as soon as we had a provider who, either was outside of that in the way they practice a little bit different or they took longer, the nurses targeted that person. And then maybe that person didn't work out and they left. But then all of a sudden it was like, okay, well, who's the next person that's the furthest out on the curve that, we're going to grieve about? So I think just being open to the fact that not everybody's going to be the same. There are going to be different ways. And there's a lot of different ways to go about doing things. But, if the provider is new to us, then, the same way that we should be going to our new nurses and new techs and introducing ourselves, because maybe they're in the awkward spot, maybe just going to that person and introducing them. And it would probably be good for them to know, like, is this person introducing themselves somebody who's been here for 15 years or 5 years and knows a little bit about how things are going? Or is this somebody who, is been here for 3 months and doesn't, is just figuring out where the bathrooms are. So I think as you're asking about like a new provider in the department, I think just being welcoming, giving them a chance in terms of things, but certainly helping, a lot of times it's not the medicine, but it's how do we get things done? So it's like, they may not know our processes and sort of letting them know where there are things that they should be doing to help our processes go. And in a polite manner, goes a long way. And not throwing them under the bus when, you walk into a room and, we're waiting for the doctor because you didn't do this right. And then upsets that whole apple cart.
Giving a little bit of grace, Sam.
Yeah.
Excuse me. Okay. Well, Kelly and I, in our own ways, both like to be favorites. I'm sure that neither of us are everyone's favorite at work, but in the goal of being the type of nurse that would be a doctor's favorite, what one piece of advice could you give nurses?
The challenge is that some of this it's innate. It's a part of us as opposed to something that you can learn. But I think the person who comes to work with a work mindset, a growth mindset of how to be, a better nurse is certainly better. Like, are we changeable or, is it too late? Are we set in our ways and are we not able to be changed? And so I think that, that nurse who comes in, it's been sad, but I've seen several nurses leave our department over 20 years. So this doesn't happen all the time, but who ultimately I spoke with later and they felt that they were tired of working with the same person that they were covering for or, making up for. And it wasn't that accountability. And so I don't know that we're not going to change those people, right? So you're talking about people who want to be better. And then there's people who ultimately, so for the nurse who wants to be better, I think, having some foresight as to what's needed, being, alerting the physician to things, but not being overly stimulating, not throwing everything at the doctor where it's distracting, but understanding the department's falling behind. I can get these NIOs done, or, and this is a situation where we can really expedite things because this patient is going to need this. What can I do to help that situation? Those are things that stand out for me. Again, I'm going to fall back to the person who's, has a really good relationship with the family and develops that to say, what are we waiting for? This is what's needed. And being that line of communication between the doctor and the patient, who I can't be in there as much as the nurses can. So making sure I'm aware, or if there's things that I missed that came out later, being a good communicator. So I know I'm across the board. I'm all over the place, and there's one thing and all that. That's a challenging thing. And I think, some of this is people need to be confident in their skills, right? And I think once you get there, then once you feel confident in the medicine, then you can be better in the relationships. I noticed that, like for me, as time goes by, if I feel more confident about the medicine, then it's easier for me to be more open in the communication with families. Like I feel like I can relax and joke with a family a little bit because I'm not feeling like I need to establish that rapport. But that's something that comes with time too.
That makes sense.
So I have one final question that is not on Sam's list.
Oh, but good job. I forgot.
But the title of this is How to Be a Doctor's Favorite Nurse. So which one of us do you like better?
No.
Me or Sam?
Kelly. That's not what I thought you were going to ask.
Well, Kelly, since you make fun of me about making a donation to the basketball pool, and you can kind of be, a little cruel at times.
I bring you toys, though. I brought you a bike horn to play with.
I do love
which I did make you jump out of your shoes with the other night.
Yeah.
My question.
So we're just going to skip over that question.
That's fine. What we were supposed to ask at the beginning, Kelly, and we forgot. Dr. Rocholl, when you heard that the two of us were going to have a podcast, this will be our last question, then we'll let you go. I know that you're busy. What were your thoughts? How did you feel about that? Did you have any, or did you not care? You may not have cared, and that's fine too.
Number one, I think it's great. Number two, I'm not surprised. I think my relationship with the two of you at work, we have a lot of conversations, and I think you're both involved with a lot of different things, and in different ways have a lot of amazing things that you both do that are beyond just being your identity as a nurse or your identity when you're at work. And so I wasn't surprised that this would be something. I guess I didn't know the two of you would be necessarily doing this together. I guess I haven't been at work enough where the two of you have been working enough to know that you would be, in this role together. But I'm not surprised that this is something that you are doing.
I think that's the nicest thing anyone said about it yet, Kelly. Thanks, Dr. Rocholl.
No, thanks.
Well, I could have said it's like the Odd Couple, but I didn't say who is in what role either. So.
Yeah, that's actually what we've gotten the most is you and Sam. I'm like, Sam and I are great friends. We're just complete opposites in every single way.
It works out really well. We just, yeah.
You're not as opposite as you think you are. I guess for me, a little bit different in the way you come across, but I think your thoughts are very similar.
Yeah. Well, Dr. Rocholl, we value you on our unit for sure. No matter what anybody else says about it, I think that you are definitely one of the driving forces of our department. We really appreciate how hard you work and that you are a resource to nurses as well. I think that you've taught us a lot. Whether the monitors are on or off, I've learned a lot from you. So we appreciate you spending some time with us. If you had a final thought, you're welcome to say it now, or we're happy to wrap up.
Well, thank you for having me and for giving me the opportunity to share my thoughts. And I appreciate the two of you as well. I'm always happy when I see that the two of you are working when I come in.
Oh, that's nice.
Likewise.
Yes.
You are a nurse's favorite doctor.
I cannot even tell you the breath that I
heard that one of our other doctors was the favorite. So I think you're just blowing smoke right now.
Oh, wow.
Nobody's made them a hat, and no one lets them into the candy drawer. So there you go. All right. Bye, Dr. Rocholl.
Bye. Thank you.
All right. So that was our lovely interview with Dr. Rocholl about how to be a doctor's favorite nurse, which should really be all of your goals, if I'm really honest about it. I don't know, Kelly, how do you feel about that?
Absolutely. I want to walk in and have a doctor say to me, "Oh my gosh, thank God you're here."
Oh, you know,
that is like the best feeling in the world.
That's the perfect way to say it.
As a nurse, I'm just like, you are welcome. I have arrived.
And better than free food, better than coffee. Yes. Yeah. Oh,
yeah. Everybody, your savior is here. That's what I want to hear. So
that's why we do this right there.
Yeah.
All right. Well, we're on all of the socials. Please let us know what good or bad experiences that you've had with the providers that you work with, what you think are ways to keep that relationship functioning, really for the benefit of our patients, because that's, as Dr. Rocholl reiterated many times, that's really the main goal. Otherwise, I think we're going to sign off for a little while. And we'll be back at the nurses station next time, and we'll save you a seat. Bye.
Bye.
Hey guys, this is Kelly from At the Nurses Station. Sam and I would like to remind you that the views and opinions expressed on this podcast are strictly our own and do not in any way reflect the position of our employers. This podcast is for entertainment purposes only and in no way should be considered medical advice. As always, consult a qualified medical provider for questions regarding your health or medical conditions. We hope you had fun listening to us today, and we'll see you next time at the Nurses Station.